Welcome to the NWA-ETC Project ECHO. I'm Kent Unruh, and I'd like to turn it over to Dr. Brian Wood, our medical director, to introduce our guest.
Well, welcome back to Dr. Dan Reddy to do another talk for us. Dr. Dan Reddy is part of our expert panel here, and she's also Assistant Medical Director for the Madison Clinic here at Harborview. I think most of you know her well. And Shrisha is going to do the second part of our CROI update talk today. And I'll turn it over to Shrisha.
Thanks, Brian. I wanted to focus on just a few studies about treatment and resistance. There was a lot at CROI this year, and I think the focus of CROI has really changed a lot in the past several years to really focus on a lot more about prevention, cure, and also hepatitis C independent of HIV. So not as much on treatment and related issues, and not a whole lot on new drugs, but I did want to talk about a few of them. The first one that I wanted to talk about was an ACTU study that compared initial first-line regimens of boosted atazanavir, raltegravir, boosted darunavir, and then the latte study, which is a new drug treatment trial, and then a resistance study from the CDC. We kind of come up with this question a lot at ECHO. There are a lot of great drugs out there now compared to in the past, and how do we go about picking what's the best regimen to use first line? So this was the aim of this ACTU study, ACTU 5257, which compared non-efavirenz-based first-line regimens. And the reason they excluded efavirenz is because of the increased risk of side effects in most studies in the efavirenz arm, the neuropsychiatric side effects namely. So if you take that one out and you have the other three, which one is better? And they hypothesized that they would actually have equal efficacy and tolerability. So the design was a 1-to-1 randomization of boosted atazanavir, raltegravir, or darunavir boosted at 57 sites. The majority of folks were on tenofovir emtricitabine and RTI combination, but there were patients on abacavir and lamivudine as well. The primary endpoint was virologic failure or tolerability failure. Baseline characteristics were pretty similar, and about almost a third of patients had a baseline viral load greater than 100,000. There were actually no differences at all in virologic failure, and I'll show you a graph of this, but there were some significant differences in tolerability. So this is a graph showing the virologic failure endpoint at 96 weeks. And so that meant that they did not have an undetectable viral load of less than 50 copies at that endpoint. It is important to note that people could switch during the study to another arm, but you're counted as your initial study arm, even if you've made the switch. So virologic failure, pretty similar amongst all the groups. Surprisingly, with darunavir, though, 15%, raltegravir 10%, and boosted atazanavir 13%. But I think this is the most more significant finding here in this study. They hypothesized that the tolerability would be pretty similar, but in fact it wasn't. The boosted atazanavir group had 14% tolerability failure as opposed to 1% in the raltegravir arm and 5% in the boosted darunavir arm. This was really mainly driven by hyperbilirubinemia and jaundice in the atazanavir group. These weren't severe grade 3 or 4 side effects, but there were enough to prompt switching in some of the patients and also report intolerance to the drug. Raltegravir, as expected, it's a pretty. It was 1% actually in the raltegravir arm in terms of tolerability failure, and 5% in the boosted darunavir arm, and that mainly had to do with gastrointestinal side effects such as nausea and diarrhea and bloating. But clearly, even between atazanavir and darunavir, there was a significant difference in terms of tolerability, and again, mainly driven by hyperbilirubinemia. Now we talk a lot about dolutegravir at ECHO. That wasn't one of the arms because that was not approved at that point had not had FDA approval. And so we may see some differences if we were comparing it to dolutegravir, as raltegravir is a BID regimen and all the other ones studied were once daily regimens. There was very little resistance associated with virologic failure. So you can see in the boosted atazanavir group, 1.5%, 3% in the raltegravir arm, and less than 1% in the darunavir arm. And I mentioned to you that it was really in the low teens in terms of the virologic failure rate, but with resistance was much lower. A lot of M184V across the board, and when they did see resistance, but as you can note, there was actually integrase resistance noted in all 3 arms of the study, even if they weren't on raltegravir. And part of the reason is that there was a switch allowed, and people did switch in the study. And then there may have been some baseline resistance as well. For instance, that K65R mutation may have been there at baseline, and it's unclear. But again, I wanted to emphasize that it was actually low rates of resistance seen despite the virologic failure rate of 10 to 15%. So moving on to the next study, the LATTE study, long-acting antiretroviral treatment enabling study. And this study has a lot of promise in terms of what studies are going to come subsequent to this one. But this was really looking at safety, tolerability, and efficacy of the oral versions of these drugs in anticipation of a more long-acting version that's going to come out. So GSK 1265744, for shorthand called a GSK 744, is a dolutegravir analog. So it's an integrase inhibitor, very similar to dolutegravir. But what's nice about this drug is that it can be formulated and given sub-Q or IM, and half-life in that version is about 40 days, as opposed to the oral drug half-life, which is 40 hours. Again, this study was to look at safety, tolerability, and efficacy, and also look at a dose range of this GSK 744 drug. And the results of this are going to go on to develop a phase 2 study with the long-acting versions. So the design, it was a randomized, multi-center, partially blind, dose-ranging study, really looking at the primary endpoint of % of those who are suppressed, less than 50 copies per mil at 48 weeks. And we don't have 96-week data yet. It's still ongoing. This is 48-week data that was presented. All patients had an induction phase that were in the treatment arms, and there was 3 different doses that they were using of this GSK 744 in the treatment arms, with 2 NRTIs that were used, either tenofovir, tricytamine, or abacavir, lamivudine. And then at week 20, essentially, they had a viral load drawn, and if they were undetectable at that time point, they went on to the maintenance phase of the study, in which they dropped the 2 nukes and added rilpivirine 25 milligrams. The rationale for using rilpivirine in this study is that there is a long-acting formulation of rilpivirine that can also be given once monthly. So the idea that you can essentially give a once-a-month regimen with this GSK 744 and rilpivirine. And the comparator arm was efavirenz with 2 NRTIs. Again, primary endpoint was virologic suppression. The study was mostly men, greater than 90%, and all the arms were men, and this is a problem with studies in general of recruiting enough women. There were 15% withdrawals in the composite 744 arms, meaning all 3 dose arms, and 29% in the efavirenz arm, again, related to adverse effects and mainly neuropsychiatric side effects. In the induction phase, so where they were on the 2 NRTIs plus the 744, there were 3 protocol-defined failures, meaning they didn't achieve undetectable viral load at that time point of 20 weeks, and there were 3 failures in the efavirenz arm. In the maintenance phase, there were 2 on a 744 and 1 efavirenz failure in the maintenance arm, so not really any significant difference. No adverse effects related to increasing dose on the 744, but there was a significant number of people who reported headache, 22% in the 744 arm versus 11% in the efavirenz arm. They made a point of saying that this was not a limiting side effect that led to increased withdrawals in the study groups. Only 1 serious AE in the whole study when looking at all of the arms, and that was a suicide attempt in the efavirenz arm, hence why they may not have included it in the previous study that I talked about. So this busy graph is really looking at the snapshot of intention to treat, primary endpoint of virologic suppression. In the induction phase, what you see is an 87% overall response rate at week 24 in the 744 arms combined, as opposed to a 74% response rate at week 24 with efavirenz. And then during the maintenance phase, so these patients had to achieve undetectable viral load by week 20 and went on to the maintenance phase, and it's an 82% in the 744 arms combined versus 71% in the efavirenz arms, and this again is at week 48, and we don't have week 98 data yet, or 96 data yet. So the conclusions are that they felt like this was at least worth pursuing. It was non-inferior to efavirenz, using an induction strategy and then a maintenance strategy. They are going to go ahead and pursue the 744 30 milligram dose and evaluate the long-acting formulation along with the rilpivirine long-acting. Some of the concerns that really came up about this study, which sounds great for a lot of our patients who are averse to taking pills daily, one of the issues is really going to be how to manage that tail. Towards the end of the month, when drug levels start to drop and patients can get breakthrough viremia. We know that rilpivirine is not first line because it's not as potent in terms of the other, when compared to other PIs or other NNRTIs, namely because that concern of patients who have high baseline viral loads greater than 100,000 having increased risk of virologic failure with rilpivirine. So if you do have that drop off in drug levels at the tail, what does that actually mean? And we don't know yet. And that's going to be the aim of the upcoming studies with this GSK 744 and rilpivirine together. So moving on, the last topic I wanted to talk about was transmitted drug resistance. And this was a large CDC study which looked at more sensitive screening analysis to look at transmitted drug resistance in the US. So we've talked about why we get baseline genotypes after someone's diagnosed, because we know that there's about a 16% transmitted drug resistance rate in the US. And that's by conventional sequencing that we use commercially, that when you order through your lab. However, we know that also there's minority levels of transmitted drug resistance that can be associated with poor treatment outcomes. So this study used about 1,000 patients who are de-identified HIV positive, ARV naive, and these were from health department specimens during a study where they were actually doing, the public health department was doing genotype resistance testing upon diagnosis of HIV between 2009 and 2011 in 8 major US sites. They actually did a very sensitive resistance assay, but they didn't look for all resistance mutations. They only looked for 5 key mutations that account for about 50% of all transmitted drug resistance. So the M41L, which is the most common thymidine analog mutation that's found, K103N and Y181C for NNRTI mutations, M184V, which is the most common non-thymidine analog mutation for NRTIs, and K65R, not because it's common, but because it has significant implications for treatment selection. So the results were, there was 7.9% transmitted drug resistance for these 5 particular mutations. Again, these only account for about half of the mutations seen by standard sequencing, compared to 13.6 by the more sensitive assay that they were using. They found that 5.4% of the cases that had been described as having wild-type virus actually did have 1 or more of these 5 mutations by this more sensitive screening. When looking at demographic factors like race, between blacks and whites, there was no significant difference in transmitted drug resistance by these more sensitive assays, but there was significantly lower transmitted drug resistance in Hispanics for some reason. And they also found that as age increases, the transmitted drug resistance rates actually decrease, and the highest rates were seen in 13 to 19-year-olds with 23% rate of transmitted drug resistance. Also of note, 33% of patients who were identified as having K65R and 58% of patients who were identified as having M184V had other mutations that were transmitted along with these mutations. And this just shows sort of by specific mutation the comparison between the bulk or standard genotype versus sensitive screening. There were no K65Rs identified by regular sequencing, but 18 or 1.7% with the sensitive screening. And I think the main ones you look at here, Y181C and M184V, were much more likely to be identified by this sensitive screening. And we know that these have huge implications for treatment decisions when we identify these at baseline. And here again, you see that the overall rates were 7.9 versus 13.6. Looking at whether there were geographic differences by standard sequencing, there was actually a difference in regional difference, and with the Northwest and the West Coast having the highest rates. But when we looked at more sensitive analysis, it's actually evened out amongst the different regions, so there were no regional differences. So conclusions, I think, this is pretty worrisome information that there is a lot more transmitted drug resistance than we are aware of, that we were aware of, but how does this translate into what we do clinically in terms of our treatment decisions? We know that a lot of these mutations revert quickly back to wild type, like M184V, but we often don't consider that necessarily when we're looking at initial treatment regimens. But this has huge implications potentially for PrEP and for treatment. And I think there's going to be a lot more investigation of transmitted drug resistance in the future, and whether we'd be using these more sensitive assays in the future is unclear.